So with that, I want to introduce our moderator for our next session. Kezia Scales is the Vice President of Policy, Research, and Evaluation for PHI. And in her role, she defines PHI's strategy for building the evidence base and advocating for state and national policies and workforce interventions that improve direct care jobs, elevate the workforce, and strengthen care processes and outcomes. She currently serves on the Family Caregiving Advisory Council, convened by the Administration for Community Living. She co-leads the Advancing Workforce Analysis and Research for Dementia, or the AWARD Network, and represents PHI as a core partner and subject matter expert for the National Direct Care Workforce Strategies Center. Thank you for being here, and you get to take it away.
What an absolute honor to be here and to be part of the conversation today. Thank you so much. I would like to invite my panelists to come up and find their seats on the podium. So, and then I'll take a moment to introduce you all. So this session, as noted, will focus in on the paid direct care workforce within the shared care ecosystem. And we'll take some time to discuss persistent challenges facing direct care workers, like low wages, limited training and career advancement opportunities, and insufficient recognition and respect. And we'll talk about the implications of these challenges for workers themselves and for the delivery of essential services and supports, particularly in the context of ever-growing demand for care. But also, and so importantly, we will focus on highlighting innovations and showcasing solutions that improve job quality, support recruitment and retention, and advance equity through both policy and practice. And who better to bring together these challenges and their evidence-based solutions than this panel of researchers, practitioners, thought leaders, and shared caregivers as well. So I'm so pleased to introduce our four panelists, in turn. I'll start at the end with Dr. Jarman Ye, who is an associate professor at the Institute for Health and Aging at the University of California, San Francisco's School of Nursing. Jarman is a sociologist and gerontologist whose research focuses on age-friendly communities, age-friendly health systems, and workforce issues that impact older adults, people living with dementia, and caregivers. Next to Jarman, welcome Jarman, all the way from the West Coast. Next to Jarman is Dr. Jasmine Travers-Aleitzer, who's an associate professor at NYU Rory Myers College of Nursing and a leading nurse scientist advancing research and policy to transform long-term care and reimagine aging in America. Jasmine's work focuses on nursing homes and other long-term services and supports and workforce issues, and she has directly helped shape both federal and state policy on these issues. And next to Jasmine is Dr. Emily Francosa, who is a research health science specialist in the Geriatric Research Education and Clinical Center, or the GREC, at the James J. Peters VA Medical Center in the Bronx in New York. An associate professor, newly minted associate professor in the Brookdale Department of Geriatrics and Palliative Medicine at the ICANN School of Medicine at Mount Sinai, and a senior research fellow at the New Jewish Home Research Institute on Aging. Emily's research focuses on developing collaborative interventions to support home care workers and more effectively integrate them into older adults' care teams. And finally, Dr. May-Lynn Anderson, who serves as senior advisor for clinical care in the Department of Pediatrics at Northwell Health. In her work, May-Lynn practices and advocates for partnership-based relational leadership in healthcare and considers this approach central to her own shared care with the numerous caregivers, clinicians, and direct support professionals when supporting her 91-year-old mother and her adult autistic child. So welcome, everybody. Thank you for being part of this panel. I'd like to start, as we often do, with the big picture, with thinking about the current landscape of the direct care workforce and what feels most urgent right now. And just to give a little bit of context on who we're talking about here, I think we all know, but we are talking about personal care aides, home health aides, and nursing assistants known by a wide range of job titles in the field, who support older adults and people with dementia across settings of care, primarily long-term services and supports, and who comprise, by the way, the largest occupation in our country across industries and sectors, and also the occupation that is expected to grow the most in the years ahead, as I mentioned, as demand continues to increase for the vital services and supports that they provide. I'm taking a little moderator's privilege here before turning over to the panelists, but this is also a workforce that really sits at the intersection of a number of federal policy actions, assaults on Medicaid, on immigration, on employment rights and protections, including home care workers, access to minimum wage and overtime, which we heard about earlier, and staffing standards in nursing homes, which we just heard about in the vignette about the challenges around staffing levels. So there are a number of factors in play right now. And so I'd like to turn it over to you all to say a little bit more about what the landscape looks like and what is most urgent. So Emily, if I could turn to you first.
Sure. Already forgot to use my microphone. Right, if that okay. So Kezia, thank you so much for that and setting it up so well. And I think our first two panels really covered a lot of this, but the current landscape, I mean, to say the least, it's challenging, right? We know there are so many more families that need help than we have workers. That shortage is growing. Every state in the nation is experiencing a direct care workforce shortage and crisis. And in my work at the VA, we talk to home health agencies, veterans, families around the country. And the number one thing that we hear is we can't find enough workers. And when we do find workers, they leave. And so what do we even do about that? So what really feels most urgent, I think, in this moment, especially given coming changes to Medicaid and other federal policy, is how do we, in this environment, stabilize and continue to grow this workforce? And I will say that working within VA, which is a national integrated health system, we really have an opportunity that other payers or health systems don't necessarily have because we provide care in every county and territory in the country. But like other health systems, we don't provide it ourselves. We buy it from the community. So we're both experiencing these challenges in finding enough workers, but also have leverage that a lot of other systems don't. And actually, here is where I should say that I'm speaking today in my personal capacity, and I'm not. This is not reflective of the views of VA. But I think the two questions that we really need to think about are, how do we grow the workforce? Obviously, we've talked about low wages, we've talked about the lack of benefits. But we really need to set a baseline of home care job, and I'm speaking specifically about home care because this is the direct care work that I do. We need to talk about making these good jobs, but also about making them jobs. That these this is work, this is a specific job that has competencies, that has consistent support, training, supervision, peer support, and so that people who are getting into this work know what the expectation is and know where they can advance from there. So that's a really important piece of bringing people in. But then there's also the question of how do we keep the workers we have? We hear so much about turnover, and in our research in VA, our team has found that the number one reason we don't use home health services is because of the turnover. Like they don't even want to get into the issue of having a worker come in and how do you even share care when somebody may not be there the next day or the next week? Why spend the time training them and getting to know them? So in that case, we really need to, in addition to improving wages and benefits, think about how we're supporting workers, how we're helping them advance in their careers, and how we're really making sure that they have training and support on the job to stay there.
Great, thank you. Yeah, so really highlighting the importance of recognizing this job as a job and the unique competencies and skills and contributions that are involved, and better matching that with the kind of training and career advancement opportunities, and also compensation that is required. Thanks, Emily. And then do you want to take this question?
Sure.
Yeah, just go to the slides. Yeah.
Perfect. Great. Well, thank you so much for inviting me all and for your wonderful introduction. I have to say that this work and this topic is really deeply personal for me. Had it been for 34 years, the primary caregiver to my autistic son, who has very complex care needs, chronic illness, and high support needs in general. At times, on any given week, I could be coordinating 10 different care partners who were coming into the home, just 2 full-time DSPs. So it's crazy. Also supporting my aging parents. And so, okay, Donita just killed me when she was talking. I'm gonna have to not think about her presentation, because that really touched my heart, having lived much of what she talked about. So anyway, I'm coming to this topic really from both sides. And what I see the most urgent care issue to be, besides the obvious structural and financial issues, is really relational. And I think that we've built a system that treats the caregiver and family relationship as a transaction. And rather than seeing it as truly one of the most important partnerships that individual and the family as well has, and not cherishing and treasuring that as a society, and looking at it in that manner. You know, on paper, it's the client and service provider, but it's really about that one-to-one interaction. It's about that relationship. It's about developing and establishing the trust and maintaining the trust. Families have to invest too, and I feel like I'm repeating pretty much everything that everyone else has said, but these are the things that are really close to my heart. We as families really have to invest too, by honestly speaking, by being really clear that there will be communication that goes both ways on a regular basis, and starting from day one with that kind of communication, and also that the caregiver's input really is not just welcomed, it's critical. It's absolutely critical and necessary. And that brings me to, and I'm going to say it out loud, and it's been talked about in the last 2 panels as well. It's really about human-centered design. And it's the end user being at that table, flattening the hierarchy so that everybody's voice is equally respected. And without that, it's very hard to be successful. It talks about what's successful. And it's very, very difficult for that caregiver to even perhaps have joy in their practice, which we really want that for them to have. We also need to recognize that implicit bias is in that room from day one, from both sides of the equation. And we really don't talk about that enough. We know that paid caregivers are juggling a lot, juggling multiple jobs, juggling care at home for others. And we need our caregiver partners to know that we see them as a whole person. That we care about them, we hear them, we value them, and that they really do make a difference. We built systems around tasks rather than the relationship that is so critical to care. And paying benefits are essential, but they're not enough if we missed the heart of care,
Thank you. Thank you for drawing out those incredibly important issues around the relational heart of this work and how to support that, as well as the other important and urgent issues that you raised. Sherman and Jasmine, would you like to add anything else about the landscape and what feels most urgent right now?
I feel like everybody has really touched on many of the critical things that I would echo as well. I think when I think of the workforce, certainly recruitment, training, and retention are so incredibly important. And I think about in the state of California, where I am, we have a master plan for aging that has built in as one of their goals, caregiving that works, with the ambition of creating 1 million high quality caregiving jobs by 2030. And I feel like this is an important nod to the direction we want to go, but certainly continued and sustained investments into workforce development programs, training, and retention programs so that we can actually achieve these goals, I think is one of the really urgent things. And certainly with all of the policy shifts at many of the different levels that we're all facing, I think, it's a challenge to navigate these times. So that's one of the things I would add.
Just to kind of add on to how we perceive workforce and caregiving work, I'm coming from the lens of nursing homes. And one of the things that I say, when we're talking about those perceptions, how can we look at nursing homes as the best places to work? So particularly when we talk about jobs and making them actual jobs, but then when we think about all of the ways in which we want to make it more relational and change the culture and we're saying more pay and things like that. I was at a conference a couple of years ago when Gerontological Society of America, and someone in the audience said, what is the headline that you want to see for nursing homes in 5 or 10 years? And another person said, nursing homes, the best place to work. And then when you see that, then you're like, wow, what if we did see that as nursing homes the best place to work? And when you think about the best places to work, what do you think about? What are the things that you're like, I love this, I love my job, I love this position. And how can we now put that into nursing homes? Those different things that you love, whatever it is, free coffee, free snacks, birds and dogs are running around, flexible schedules, people saying, hi, how you doing? Bringing your kids to work. Can we put those into nursing homes so that you're like, wow, like where I work, and yeah, it's hard, but it's great. People care for me. People have my back. And I know that this is a place that they are investing in me. So that's one of the things that I would love to see when it comes to the conversations of improving the workforce and making it a place where we want to recruit people and retain people. We need to change the ways in which we even set up the culture within nursing homes specifically, where it is like the best place to work.
I love that. That's such an inspiring image. And I like thinking about extending it across the full direct care workforce and thinking, what if these were the best jobs to have? And how much would need to kind of align and realign around the jobs and the people getting served and supported and their family caregivers and the places that they live and work to make that possible. I mean, that's the dream.
It could be reality. We have places that are the top 10 places to work.
Yeah. And this, again, coming back to the fact that this is the largest occupation in our country, like there is a real clear imperative to invest more in this workforce and think about how to make these the best jobs so that we can recruit and retain enough people to meet the needs of older adults and people with disabilities in our families. So the imperative is absolutely there. Okay, we're going to move on to the next question. Considering that this is a workforce that is overwhelmingly female, about 85% of direct care workers, and majority people of color, and disproportionately immigrants as well. And this sort of demographic profile of the workforce has deep historic roots and continues to impact the jobs and the experiences of those in the jobs. So with that in mind, what does equity mean in and for this workforce? How do race and gender and immigration status disability and other factors intersect with job quality and worker recognition and voice. Jarman, I'd like to start with you on that one.
Yeah, so this is a massive question. So I would certainly kick us off, but open to hearing, other perspectives as well. But, I think a place to begin is that we really need to see equity in this workforce, not as an individual experience, but really something that is structural. And it reflects the structural decisions that have been made over time around whose labor is valued. Certainly, the demographic of this workforce is not coincidental at all, but it reflects, is the product of several policy choices over history that has, excluded labor protections for home care workers, domestic workers. And I think that also, the fact that this workforce is predominantly made of women, people of color, and immigrants, they've been systematically already excluded from being at the table and having their voices heard. So equity isn't just about wages or about compensation, but about whose voices are being heard and how are their stories being told. So I think that's sort of one piece of the puzzle. Certainly race and gender are confounding factors. The sort of triple jeopardy of invisibility that this workforce faces is part of the issue as women, as people of color, as immigrants. And the I think, implicit bias that was brought up, the racial bias that is bidirectional, multidirectional, across several different interactions, between the direct care workforce and their employers, with agencies, with care recipients and their family members. I think that there's sometimes very little institutional recourse that can be in place to sort of help mitigate some of those tensions. And, those are really real daily realities that this workforce has to navigate with tremendous amounts of emotional labor that is placed into that work to navigate daily interactions, just to sort of smooth over what is really sort of structural issues impinging upon the everyday lived experience. And then just to quickly sort of touch on immigration policy, I think immigration status is a huge vulnerability for this population, and we're going to need much better immigration policies for us to even dream about fulfilling the workforce needs to meet the demands of supporting older adults and other people in our communities and in our lives that are going to need caregiver support. Certainly, the Trump administration has enacted many policies that are harmful to the direct care workforce. Immigrants are at higher scrutiny by ICE raids. They have to have their paperwork sort of all in place and, be really sort of on point. The immigrant workforce is also more reluctant, likely, to raise any, bring issues to their employers for fear of retribution, for fear of some of the ways in which they might be reported and lose their jobs. And I think that has a real impact on the care that they're providing to care recipients as well. So, that's like the tip of the iceberg, but maybe I'll pause there and happy to hear what others have to say too.
Yeah, that's a really talking and it's fun. Thank you. And this is such an important and central question. So I think I would like to just move down the line if you would like to share, Stephanie.
Sure, Carolyn Jackson. No, thank you for that. You set that up so beautifully. And just thinking about what Charmin just said and thinking about the demographics of those who are working in these positions, something that was shared by our direct caregiver who was on one of the vignettes, and something that I've seen, these certified nursing assistants within nursing homes, they say, I love the job, but it's the job beyond the job. So the other experiences that they have that make it hard to actually do their job. This direct worker was getting at it. So I've heard CNA say, I'm kicked, I'm spit at, I'm cursed at. If this were to happen in another position, kicking, like that's assault. People would have been arrested. But instead, this happens often and often to certified nursing assistants, direct care workers in the nursing home space. And they don't have protections. Many cases, folks don't even check in on them to see if they're okay. This happens in front of folks, in front of other workers, in front of their leaders, in front of family members. So how are we actually protecting folks and saying, you know what, this is not okay? If I see you get kicked out, not even just through the words that are being said, racial slurs, the ways people are being treated, where I have found that nursing assistants have said that they experience more racism within the nursing home compared to outside of the nursing home. And these are harms that folks are experiencing day in and day out.
Every day.
And they don't have the supports from their peers, their coworkers, other staff, or their leaders. So how are we actually training leaders to be able to support these people who are experiencing this? How hard is it to actually experience that every day when you work? So those are the things that we need to think about when we're trying to figure out how do we actually care for a workforce. And if you saw someone right now, you know, I'm looking at you right now. If you came and hit Raj right here, we'd be like, what just happened here? Raj, are you okay? You know, the least thing that we could do is say, hey, are you okay? Like, that was not okay. You just experienced a harm, and I want to check in on you. If anything, if not, you know, really like, all right, maybe we need to hold the video, right? Not done. Yeah, we need to hold it back. We don't know what just happened here, you know, but like, how do we actually respond and show people that we care about you? And then there's so many other just inequities that we're seeing when we don't know how to care for folks with different, how they identify, like there's not enough training in that. So then we're experiencing that with how residents show up to staff. So really creating that culture where it is, hey, if you experience racism, we care for everyone, or you're probably going to get cared for by this person, and this is what that looks like, and this is how we respond. So really having a system to how do you respond to these issues within a setting to be able to care for your workers.
I don't have much to add. All the wonderful things that my panelists, really smart things my panelists have said. One thing, Jasmine, that this makes me think of is going back to, you know, is this job a job? And if it is, then it should come with a safe workplace, protections that we expect in other parts of our lives. So, you know, the same way that, you know, a cashier at a grocery store or a researcher in a, you know, school of medicine would to depend on. But the other thing that I just wanted to add is that in the context of shared care, when we're thinking about equity and how that shows up, is that these jobs and this work, care work, has been very easy to dismiss, not just because of who is providing it, but also who they're providing it for. And I think we don't often think a lot about how ageism and ableism and in the way that we think about the people that we're caring for, both our family members and the people that in the direct care workforce. So that's one of the reasons that I actually think this growing advocacy movement, and we talked in one of the earlier panels about these broad coalitions of workers, of care recipients, of disability and aging organizations together. This, I think, is really powerful because socializing this idea of care as a collaborative effort, as a needed effort, as something we're all going to have to deal with in our lives, either as being cared for or caring for others, that's really helped policymakers see that this is an important issue that's not going away, and has brought it out of, you know, the private homes and the nursing homes where we don't really see care happening in the streets. So that I find actually very heartening.
I really don't have that much to add because that was awesome. But what came to mind when I originally read this question that you posed now, implicit bias came to mind, and I saw it with my own mom, and I'm not particularly happy to say this out loud, but I will. My mother has increasingly developed more, her dementia has evolved, put it that way, very quickly. And she's been falling a lot. And when we first engaged a caregiver, she came to the house. She was wonderful. She was somebody's sister-in-law who I knew and deeply respected. And I was so excited and felt so great about this match. I thought, she's right in the room. And my mother, who has lost some filter, says out loud, "Why can't we have somebody with an education here helping me? I need somebody smart here with me. She doesn't have enough to talk about with me. And I need somebody who takes care of their bodies and watches their weight." And I was mortified. And of course, and I was shocked because my mom has always been super kind and putting herself out there to be warm, especially to people who probably are disenfranchised. So I was amazed that, in a negative way, that probably has always been running through her mind. And it just, the switch flipped. What was equally upsetting to me was the response of this wonderful woman who just sat there, head down, and just, didn't need to leave the room. And man, oh man, I really felt very uncomfortable. So it's not specifically a solution, but it's my personal observation.
Thank you for sharing that. That was a hard moment and probably hard to share. So I appreciate your honesty and I appreciate all of your answers. And I think collectively what you all have shown so poignantly is that equity issues around equity and inequity play out at every level, from the sort of highest level federal policy around immigration all the way down to that very direct personal interaction between two people. And so the sort of corresponding supports and fixes are needed at every level as well, at the policy level, federal policy level, state policy level, at the employer level, and in the interpersonal shared care context of family caregivers and direct care workers together with their with the person receiving care. So much needed there around sort of change, but also the kind of education and training, and what does it take to kind of acknowledge and then be able to move on from or sort of resolve some of these deep rooted challenges. Okay, I'm going to move us on to our next question. And we might move a little bit more quickly through this question because our final question is about solutions, and I want to make sure that we get there and spend enough time there. But as we've talked about already and we've heard about already today, there are a number of longstanding challenges facing this workforce around persistently low wages, limited career training and career advancement opportunities, leading to high turnover, a very dynamic workforce. And I just wonder if we could speak a little bit more about why these issues, they're really well recognized. There's been lots of efforts to address them, but they persist. Why do they persist, and how do they show up in day-to-day care? Just going to mix this up here. Jasmine, would you take that one?
Sure.
Thank you.
I'd say, why do they persist? One of the things that has come out is ageism. Talked about the undervaluing of those who care for our older adults and older adults themselves. So that I have seen a lot of the lack of investment in these areas. They're like, oh, pay people more. Well, how much? Should they get paid more? We talked about, kids and children and how it takes a village and villages surrounding that. But then when it comes to our older adults, we don't recognize that we need to actually pay people a living wage and such. So that keeps us from really putting those investments where they need to go. I love just connecting with how important it is when we talk about even the demographics of those who are providing this care and what keeps us from paying them the money that they need to actually, making their covering utilities, they're covering mortgage, rent, all that kind of stuff. $12 an hour, $13 an hour. How far does that really go? Not really anywhere. But as far as how does this show up, one of the things that I think we need to do a better job of as well is really connecting these issues that we're studying when it comes to turnover, when it comes to staffing, connecting it to the residents and the patients themselves too. We've asked residents, what does it look like to not have a registered nurse on? Not just say, all right, have a registered nurse on site for 24 hours a day. That's a policy recommendation that we had put forth and has not gone into play yet. But a resident told us, I take special medications and only an RN can give me these medications. If there's not an RN on site, I don't get my medication. If they can't call someone in and talks about agency, and someone talks about agency and sometimes the inability to get agency folks on, then I don't get my medication. Or if there's not enough staff, nursing assistants on staff to answer call bells, I'm sitting in my soiled garments for hours and hours and hours. I shouldn't even have had to soil myself. When we think about dignity, and then just in general, when we think about just the care that needs to happen to make the day grind, airplanes, especially there's been a lot of stuff going on with airplanes these days. I've been very scared. But airplanes don't take off if they don't have enough staff. Why do nursing homes do so? This person comes up, 2 people on, 2 certified nursing assistants on site. And we're like, oh, we heard about their flight in New York. Oh, they were short staffed at night. They're short staffed on nights every night in nursing homes. Why do we let this happen? That's all I have.
Thank you. Anybody else want to speak on this question before we move to the last one?
Make a couple of points around just sort of how it shows up in, day to day. A big portion of my work in California is looking at the Medicaid-funded in-home supportive services program, and that's primarily 70 to 80% family members that care for a loved one or a friend or a relative. And many of them are also holding other jobs. They're CNAs and IHSS and maybe working, at Starbucks. And so I think, thinking about the direct workforce, they're not mutually exclusive categories by any means. And so that's sort of one part of it. And from the stories that we've heard from people in our studies, especially in the rural parts of California, they're driving long distances to these jobs. And those, gas is not a compensated part of what they do. And it's a significant part of the cost that they have to sort of bear to do this work. So I just want to sort of highlight that piece, and going back to immigration and thinking about the very diverse direct care workforce. I know in California we have multiple trainings in multiple languages, but I often think about people who are not maybe English fluent, are not part of policy conversations, or may not participate in research. And those are some of our limitations as researchers, to develop tools and instruments that are validated in multiple languages. But I'm just, sort of thinking about sort of whose voices are not heard, and then therefore how are their sort of day in, day out experiences sort of omitted from the ways that we're thinking about informing policies and programs.
Yeah, and I won't take too much time, but I did just want to add that I think one of the things we heard really strongly from Donita earlier is this question around it, kind of bringing this back to shared care, this question of credentialism and scope of practice when it comes to direct care workers, and thinking about what family caregivers are expected to do versus what the limitations are on what direct care workers can do. On one hand, you have kind of this task inversion of family caregivers changing catheters, doing advanced wound care, having to do all of these really advanced medical tasks in the home that the people who are coming in to help, you can't offload those tasks onto them because, somebody can't even crush a pill. All they can do is a medication reminder. So I think that's the way that it shows up in shared care in a very stressful way for both workers and for family caregivers.
Just one brief add, reflecting on Courtney's mention of the individual who had 40 different caregivers in and out of their home, and the impact on that individual and that family is just profound. And we expect them to welcome them with open arms and to trust and to repeat their life story over and over and over again. And they have burnout too, and it's very, very difficult and challenging. And it just perpetuates that cycle because they become less welcoming. And they don't want to open up their hearts and trust again and establish another new relationship.
Thank you all very much. So I think you have articulated so well the sort of some of the drivers of these long-standing unaddressed challenges. One that I heard was that the system, sort of to segue us into the solutions part of the discussion, that we have really failed to fully account for the full costs of providing paid care as a member of the shared care ecosystem. So all of the costs that you spoke to, Jarman, around gas, mileage, and but also a living wage for the people that are doing this work, and training, and all of the things, like really actually thinking, what does it cost to employ someone to provide quality care for someone who needs it? And how can we build that into payment mechanisms and reimbursement systems and things like that? But also, to Jasmine, to your point, then following, sort of connecting that investment to what it means in terms of individuals' experiences of care and their outcomes, and what is maybe mitigated or prevented as a result of that. So trying to follow, like, it makes sense to put that money into this workforce, among other investments, so that individuals receive the care they need when they need it, so that they don't end up in hospital or in other sort of avoidable and more expensive outcomes, which are really damaging for the individual and their families, but also costly for the system. So that's the kind of bigger picture that we really need to try to wrap our arms around. So what do we do? Given these challenges that we've discussed and the growing demand for care, what needs to change to make direct care a sustainable and valued career? What kind of concrete actions can be taken, policy actions, organizational changes, community-based strategies to strengthen and sustain the direct care workforce? I'm going to start in the middle here. I'll go back to Emily first, but I think we want to hear from all of you.
Yes, I'm just gonna, there are so many things I could say, but I know we're short on time. So I do just want to highlight that, as we've acknowledged, it's a challenging time to push federal policy forward. There's a lot of really exciting innovation in the states. I think, sometimes that blockage on the federal level really opens up a lot of opportunities in other laboratories. But I will actually point to one organizational or system innovation within the VA. VA has been testing a make versus buy pilot, where we've essentially been hiring direct care workers into primary care teams. And the evaluation of that was just completed. This was particularly to reach veterans in very rural areas who have a very difficult time finding workers. Not to my surprise, the pilot was super successful. Veterans and caregivers really loved having somebody who was a known and trusted member of their VA team. They thought they were better trained. They thought they were, that they were higher quality than what they had been getting from agency aides. Primary care teams loved it because they had eyes and ears in the home. They knew what was going on with their veterans. And aides really loved having the stability, having a job with benefits and a regular schedule, being able to develop these relationships over time. So obviously that's something that is reaching a very specific group within a very specific system, but I do think kind of sets the bar for the kinds of things that we could be testing and looking at and scaling to improve care.
A great example. Thank you, Emily. Jasmine, can I go to you now? Thank you.
Sure. One of the things that I think our organizers have done a really great job is getting all these folks together who are doing some incredible things. And I think about how do we get the work that we're doing, when thinking about making change more on a local, to more of a local level. Myself and Norma is working on a project where we're looking at a program that provided funds to small businesses from many nursing homes, if not all of them, were considered small businesses. And these funds said that you had to dedicate the majority of them towards staffing. And that's what nursing homes did. They dedicated it towards staffing. We looked at how did staffing patterns change, and then how did resident outcomes change. And in poor neighborhoods, we saw that resident outcomes with regards to hospitalizations and emergency visits improved significantly among nursing homes who receive these funds. And then we also saw improved staffing patterns. But then we also asked the nursing homes, what did you do with the money? Not just looking at it quantitatively, but qualitatively, like what types of programs did you invest in? And one of the interesting things that a nursing home said to us is like, we got this money, but we didn't know what to do with it. And I'm like, what do you mean we didn't know what to do with it? We put it towards staffing. And they're like, what works? What's like the best thing? Like, where do you put the money that we're going to get the biggest bump? If we're going to increase wages, how much? If we're going to do bonus pays, whatever. If we're going to like help with the culture, what kinds of things to do. So some things that folks did do were like themed days where you come in and you like wear your stress down day where it's pretty fun. Or they did a lot of recognition where everyone got like a gift every month where they felt really excited about. Or they also created an app for folks because transportation was a big thing where through the app they could communicate and say, hey, can we do a carpool system? And that really supported people getting to work. So how do we kind of take some of these, all these like innovations that we have and make them really realistic for nursing homes? Because also they say like, well, yeah, you come here and you do the study, and then now like, we actually can't afford that, where it's not like that full like intervention or something like that. But make it really make sense for the nursing homes and communicate that information. That's one thing I would leave.
Yeah, thank you. Thank you, gentlemen. These are wonderful, really tangible, sort of practical ideas. We're going to move to our audience Q&A or our participants Q&A, but just real quick, we do want to hear from both of you. So, Jeremy, if you'd like to go.
I think one of the things that came up in the first panel that I think really resonated with me is just the coalition building needs to happen to sort of really move some of the larger political bill. And I think part of that is to change the hearts and minds of policymakers through narrative change. And so as a qualitative researcher, I really love the way that lived experiences in these vignettes have been interspersed throughout today's session. I think that's been beautifully done. And I think, again, as a qual researcher, nothing is more extraordinary to me than the mundane, the ordinary, the everyday, because I think that that's where we see the complexities of policies and systems impinge upon people's everyday lives. So telling those stories.
Thank you so much. Okay, Maylin has very generously yielded her time on the last question, so we can move to the Q&A. Thank you.
Great. Before you, can I borrow you tonight? Sure. I just want to recognize that we have a Zoom audience asking questions. So I will ask one question. I will go right to you guys, but it's a good one. Last year, the administration decided not to enforce minimum staffing requirements for nursing homes. Could the panel speak to this? Is this a bellwether for long-term care trends as a whole? Should we be relying on care providers to improve quality rather than government regs?
It's like a thousand. Again, this is a very controversial question. For me, and I know for folks who see this differently, I was saddened that this was turned down. This is something from the National Academies that we said we recommended as far as minimum staffing standards, and it goes back to my point of planes don't take off if they don't have enough staff. Why do nursing homes do so? And we've gone through how many years and decades of nursing homes having the opportunity to kind of get the staffing right, and they have not. And for all the different reasons. So I do think that there needs to be additional supports to help them get the staffing right, whether it's on a state level or a federal level. But within that, not just kind of setting, you need to have this amount of staff, but being thoughtful about how are we going to support you to get the amount of staff that's going to meet the needs of your communities.
Sorry, burning question here. About a month ago, I was in the same building because the National Institute on Aging had a conference on AI and the future of that. What role is technology going to play in how is it going to impact the direct care workforce? Because in Japan, for instance, there's like actual robots lifting patients to, support people. And I'm not making, I was stunned when I saw this. We've had adult day programs that have had Moxie robot come around and say, it's like having another staff member. So what is the role of technology in supporting the direct care workforce in the next 10 years as a solution to some of this?
I think we cannot AI our ways out of a care crisis. And, you can have robots helping with transferring, and you can have, the little adorable seal that they bring into, what's his name? But you still need people to do the work, and you still need people to have those relationships. And I worry that especially in the home care context where, these patients are often, or clients or care recipients are often already marginalized, isolated, that relying on technology instead of people further marginalize the cycle.
I would just add, sorry. I think that's a great answer, and it's a really important question. I think we've already heard today that these settings of care are also not necessarily on the cutting edge of technology.
Exactly.
And so I think there's places that we can maybe be focusing more on how to kind of backfill some of those technological supports. So there's sort of persistent challenges around scheduling and efficiencies around sort of more staff supports and training and things like that. And I feel like that's where we should probably be focusing that AI excitement, is how to just better support the workforce that we have so that they can focus more so on providing that interpersonal care that cannot be replaced.
I love that. I'll just add one thing, something that we heard from residents, like things like Alexas. We have Alexas in all our rooms that just turn off our lights when we say turn off our lights. Easy things like that where we have to wait for someone for how long just to come in and do that. So there are some things where we can think about efficiencies that will support and relieve the workforce within the nursing home setting, where it's not replacing some of those important things that we need, but offloading.
Yeah, great. So we are about to arrive to lunchtime, but I do want to take a couple more questions. I see there's some excitement, but let's try to be brief so we can hear from more people.
I'll talk really fast. My question is for rural population. So in California, I do business in like 25 out of the 50 counties in California. We're growing. So there are about 10 that I know I can't do business in because I can't find a home care agency that's actually going to staff, despite us paying $35 an hour from the Medicare guide model. So I'm just curious, from your perspective, when you think of innovation or like challenges to bring care to those people that need it most in like rural Northern California, and as an example, what comes to mind?
I feel like we need to chat a lot more. It's a huge problem. And I think that how do we create these good jobs? How do we encourage people to either move to some of the rural areas or build the capacity within some of the rural areas? I know in one of the projects that I'm working on in a rural county in Northern California, they're working with the local community colleges and their SNF to build workforce pipelines there to sort of grow their capacity. One of the challenges that they face is, housing. They are sort of limited in terms of being able to build more housing. And so I think that, we have to sort of think about lots of different solutions that may not be directly about the workforce, but then will ultimately address workforce issues. So that's just a really quick answer, but I'd love to chat with you more.
Thank you.
Okay, fast as I can. Just not a question, but kind of highlighting something. The impacts of the One Big Horrible Bill Act, right? People think about the cuts in services in terms of home and community-based services. We all know things are going to get cut. But one thing I want people, I don't know if anyone's thinking about this, but the impact on direct care workers, because the work requirements are going to make a lot of these people lose their health insurance. And then the other part of it too is that family caregivers are also likely to lose their health insurance because you have to prove that you're a family caregiver. So all of that is really going to have a terrible impact on both those populations.
Thank you.
I'll try to make this quick. This is something that I've been wondering about for a long time, and I was reminded of it when I believe it was Jasmine was talking about making nursing homes or the care settings the best places to work. What about unionization? Like was wondering, in terms of self-determination in the workplace, in terms of better pay and benefits, what role does collective bargaining play in this workforce, and where are some barriers to establishing it?
You have something?
Yeah. I can speak to that. In answer to that question, it has a tremendous difference. We know that union workers that have higher pay, better benefits, higher retention, and even that there are spillover effects. So in a state, I think this is PHI research actually, that in states that have higher union density of direct care workers, other non-unionized direct care workers have higher wages and benefits. So it really is a tremendous, there are a lot of barriers to union organizing. And even though it's grown tremendously in the direct care workforce over the past 10 years, it's still only about 10 to 11% of the workforce because of a lot of the federal barriers and policies that Charmin had mentioned. But it's a great model and one of the greatest engines for equity in this workplace. And I'm sorry, I know we're tight on time, but a lot of the healthcare unions have also really adopted this philosophy of bargaining for the common good, where they're negotiating not just for their own wages and benefits, but also for their communities and the people that they serve. So I think there are some really important coalition building lessons there too.
Our final question.
Good afternoon. I'm Kareem White, and I'm over 37 years in the healthcare, CNA, GNA, and a CMT. My mom always told me, ask the question that nobody's not going to ask in the room. So my question is, do you believe if we make it mandatory, a mandate to make corporate come in to these facilities to see what's going on, to see how staffing being treated, to see how residents being treated, and then they can get an understanding of what's going on inside their business? Because a lot of times you find out corporate don't know what's going on. They don't understand why they keep being short. They don't understand why people quit in the facility. So my question is, do you believe if they make a mandate, these corporates, these facility owners to come and see what's going on in their building, that a change become about, a change that will make a difference around the board, not just in the state of Maryland, but from state to state and country to country?
Thank you so much for what you shared, your question just now and what you shared previously. I would hope so. But I don't know if that there would actually be a change. I don't know if there would be that enough of a heart to say, okay, well, let's go and, let's take the funds here and move it towards here. I feel like there are some people who say, hey, this is what's going on, and they're still not responding. But I do appreciate what was shared by Dr. Barnes earlier, where she said, come spend some hours with me. So not just come and look at what's going on, but I need you to like you said, look at what I'm doing, but do what I'm doing. Feel it.
Told them nothing in an hour from people like us that work 30 years. An hour won't show them. Maybe we need to do undercover bosses.
Yeah.
Good morning, my name is Vivian Boone. A question for you to take to lunch with you. What would a collaboration of Department of Health, Department of Labor, the RSAs, Residential Service Assistants, what would it look like to have one of each of you to represent one of each, and just like in one building, what would it look like, or what would it feel like to have all these one of each at a table together, always, or in one building? Because I'm a home care worker. I've been a home care worker for 35 years. There's no place that you can go and look to see how many home care workers are in Maryland, or how many home care workers there are. There's nowhere. There's no database. There's nothing that you could track us, but yet we're out here. We're the second hands of nurses. And we're so low to the ground that you don't even know we're there.
Yeah.
Our pay is $12. We get injured. We don't have benefits.
Yeah.
The agency doesn't give us benefits. I could go on, but I'm gonna wait my turn.
I think the participation and all the questions really show this has just been an incredible panel. So thank you to our panelists, moderator, for being here. And this brings us to lunch.